Hi guys, welcome back. We shall now be talking about acute kidney injury in a patient. You would have noticed that nowadays we don't use the word acute renal failure because failure will occur after an injury. So our objective is to pick up the disease earlier. We are now using stage 1, 2 and 3 to classify the damage that would be occurring in the kidney parenchyma. The parameters to be considered in this classification are serum creatinine and urine output. Normal urine output is 1 ml per kg per hour, and in these patients it will definitely take a hit and would go down by as much as 50% and even more subsequently. So if you read a question in which it is mentioned that the serum creatinine of the patient jumps up to 1.5 to 1.9 times of normal, then this increment of serum creatinine along with the reduction of urine output to 0.5 ml per kg per hour. Mark my words there. Earlier I was saying 1 ml per kg per hour. Now I'm saying 0.5. So it's a 50% reduction over a duration of 6 hours. Then we will say that person is having stage 1 AKI. Stage 2 is very easy to remember because you can remember for number 2, and I usually don't find anybody making a mistake in that. That is 2 to 2.9 times of normal increment in the value of serum creatinine. The urine output of the patient is down to 0.5 ml per kg per hour for a duration of 12 hours. When it comes to stage 3, nobody will make a mistake because it is number 3 to be remembered, an increment of at least more than 3 times of normal with urine output down to 0.3 ml. So here it is not 0.5, that's the only point to be remembered, 0.3 ml per kg per hour for 24 hours, and that would be stage 3. You can see here that it's very unlikely that you will mess up for 6, 12, 24, very straightforward. It's unlikely that you can ever mess up for stage 2 and stage 3. So mostly they'll ask you stage 1 only because stage 2 will be 2, number 2 to 2.93 would be more than 3 times, or maximum we can say that the absolute value of serum creatinine in this case is more than 4 milligram percent. That is obviously more than 3 times the normal. I mean, if you take upper limit of normal as 1.2, 1.3, then serum creatinine of more than 4 is obviously more than 3 times the normal. That would be substantially increased and would be called as stage 3 with obviously a decrease in urine output of an individual. You see, I'm not going to wait for a person to develop an anuria and then say that, okay, your kidney is damaged. We want to identify damage to the kidney relatively earlier. In fact, nowadays the guidelines are that why should you wait for as long as 6 hours to say that, okay, your kidneys are damaged. We should be able to pick it up in the first hour or the second hour. Like a person had a MI, he went into cardiogenic shock, then there's a kidney impact, the urine output is dropping. Or a person underwent a cardiac surgery under cardiopulmonary bypass. The problem in cardiopulmonary bypass is that it is non-pulsatile flow. And non-pulsatile flow will reduce the blood supply to both cortex and medulla, and outer medulla is very vulnerable to hypoxia. So in cardiopulmonary bypass, due to non-pulsatile flow, the medulla can undergo necrosis. There could be acute tubular necrosis occurring in a patient. So you read about post-operative patients developing a renal failure. So if a person is having post-operative renal failure, I should be able to pick it up early. That is why nowadays they have started asking regarding biomarkers of acute kidney injury. Like in myocardial infarction, biomarker earlier one would be elevated troponin I, and ECG findings will anyway develop. But sometimes ECG findings may not occur, or the ECG findings may not be very specific to diagnosis of MI if there's a coexistent conditions like bundle branch block, etc. But troponin I elevation will tell you there is necrosis. Similarly here, biomarkers of acute kidney injury, which should be remembered for the current perspective of the exam. The first one has a very peculiar name, that is NGAL, that is neutrophil gelatinase. In fact, when you read the name first time, the impression is as if you are reading about a molecule which is related to immunity. That is why I've written it first. Biomarker, which has a very peculiar name, neutrophil gelatinase associated lipocalcin. This NGAL will be checked not in the blood. It will be checked in the urine of the patient. So urinary NGAL values help you, elevated values help you identify acute kidney injury even before stage 1 starts. The next one, most guys are able to answer, and you would have read also so many times, KIM1. That would be kidney injury molecule 1. The third molecule to be remembered is interleukin 18, IL-18. All these parameters are checked in the urine of the patient. So urinary NGAL, KIM1, interleukin 18 are markers or biomarkers of acute kidney injury. If they ask you to select first, because in the book it is first written KIM1, so that is what I put a mark on to highlight single best answer. Obviously all three are biomarkers of acute kidney injury. And when it comes to identifying the damage in the patient, we also need to identify that what is the etiology simultaneously, because then you can aggressively manage the patient. Let me say a person is having a blocked Foley's catheter, that would be a post-renal cause. If a person is having diarrhea, rice water stool, and the circulation is compromised, that would be a pre-renal cause. And if a person is having nephrotoxins, like this person consumed antifreeze, that is the coolant in the car radiator, then in those circumstances, the patient will be having a tubular necrosis or multiple myeloma, there would be a tubular damage in a patient. So I simultaneously, when I'm evaluating the patient that yes, the kidneys are getting compromised, I need to find out the etiology also. So let us now look at the etiology for development of renal failure, which is artificially classified as pre-renal, renal, and the post-renal variety. Out of the three varieties, the most common one that we encountered in clinical practice is the pre-renal variety. Here I am forced to mention a page of Harrison, that is 2099, 20th edition of Harrison, that mentions that pre-renal variety is the commonest one. Why I'm having to do that is because I got queries saying that some portals or some apps have told that renal variety is the most common one. Well, I'm giving you the reference of Harrison. You can check by yourself on that page. It is written categorically that the commonest subtype of acute AKI is pre-renal, right on the first page of acute kidney injury chapter. Now in the pre-renal variety, it is hypovolemia under perfusion. The best example I can mention is rice water stool in cholera. The purge rate was very high by the child. The child from village was brought to primary health center and then to a district level hospital. The circulation of the kidney failed. Another cause for this could be congestive heart failure. The perfusion of the kidney has been compromised. The third cause that you need to remember is a person of massive ascites. Let us say this is a patient of alcoholic cirrhosis who has developed massive ascites. Massive ascites is a condition where there is redistribution of fluid in the peritoneal cavity. I mean, after all, the fluid should be in the blood vessels, but here the fluid is in the peritoneal cavity of the patient. So massive ascites patients will be having a reduction in the amount of circulating fluid volume. I repeat my statement here. Patients of massive ascites will be having redistribution of fluid in the third space. Fluid should be in the blood vessels, so circulating fluid volume is lesser, so blood supply to kidney will also be lesser in the patient. Therefore, you would have seen lots of time that when the liver will fail, the kidneys will also begin to fail. I am talking about the most important MCQ wise, not the most common cause, but I'm saying MCQ wise the most important pre-renal cause of acute kidney injury that you need to remember, which is called as hepatorenal syndrome. What it basically means is that you're having a patient of massive ascites. Since he did not take proper treatment or you did a delayed diagnosis, whatever, the circulating fluid volume and the perfusion of the kidney is reduced and his creatinine is shooting up. In a cirrhotic patient where albumin is lesser, you are having a rise of creatinine. We call it hepatorenal syndrome. It is further of two varieties. That is why I have shot a separate lecture on hepatorenal syndrome that you can watch in the liver section. In hepatorenal syndrome type 1, you will be having a stormy onset where a person of massive ascites will deteriorate as early as a little time frame of 2 weeks. In a 2-week period, the serum creatinine of the patient will shoot up to as much as a value of more than 2.5 milligram percent. That is almost double of normal. You have ensured normal perfusion of the kidney. You might have given a fluid bolus to the patient just to be sure that okay, the kidney perfusion is good. You have even stopped diuretics in the patient, because you see normally you give spironolactone to all patients of ascites. So you thought that maybe the patient is having over usage of diuretics, that is why the blood supply to kidney is lesser. So I have taken all the due precautions. I have stopped diuretics to prevent any dehydration of the patient. I have given a fluid bolus to ensure normal perfusion of the kidney, but still the creatinine is rising and is going even beyond these values in a span of as little as 2 weeks in a known case of cirrhosis. Then it is hepatorenal syndrome type 1. On the other hand, hepatorenal type 2 will be seen relatively developing gradually and would be seen with people with refractory ascites. For refractory ascites, we might have to go in for shunt surgery like TIPS, or we might continue with the same treatment if the person does not want to go for TIPS. But hepatorenal syndrome is a cause of development of pre-renal variety of renal failure, or the etiology behind it is pre-renal, because I explained the concept again. The persons with ascites have decreased circulating fluid volume as compared to you and me. I mean, the fluid should be in the blood vessels, it is redistributed in the peritoneal cavity, so the perfusion of the kidneys is compromised. Coming to the fourth point, the explanation can be understood like this, that the afferent arteriole and efferent arteriole. So AA is afferent arteriole, EA is efferent arteriole. Afferent arteriole works by vasodilation. Efferent arteriole does vasoconstriction. Please appreciate how do we maintain our normal GFR. The afferent arteriole will dilate and the efferent will constrict. So there will be a generation of pressure in the glomerulus which is responsible for filtration. I repeat my statement. The afferent arteriole dilates thanks to prostaglandins. So blood will flow and efferent will constrict. So there would be generation of pressure in the glomerulus that will help in filtration in a person who is, let me say, taking non-steroidal anti-inflammatory drugs. Like I have a patient who is a known case of chronic heart failure. This is an old man, chronic CHF. He's having osteoarthritis of his knees and he's taking painkillers daily. Now, a known case of heart failure with, let me say, osteoarthritis is taking painkillers regularly, then NSAIDs will inhibit prostaglandin synthesis, and prostaglandins were responsible for afferent arterial dilatation. Now, afferent arterial dilatation will not occur, so therefore, the blood supply to the kidney will be compromised, and that is a pre-renal variety. So, why do you read that NSAIDs are a cause of pre-renal variety? Is primarily because the afferent arterial vasodilation, which maintains the GFR, which maintains the flow to the kidney, is compromised. Let's take another example. I have a patient of renal artery stenosis. He's unfortunately a patient of bilateral renal artery stenosis. It's a therapeutic misadventure, and the doctor has started him on ACE inhibitors or ARB. In a person who is having bilateral renal artery stenosis, already the blood supply to the kidney is reduced. If you will give ACE inhibitors in a patient, it will further deteriorate the perfusion of the kidney, because after all, angiotensin II maintains perfusion. In this particular case, the balance between the afferent and efferent arteriole will be disturbed by using ACE inhibitors, and therefore the perfusion of the kidney can be compromised. Another reason for this can be cyclosporin. Nephrotoxic drugs should be fitting into renal variety. Please appreciate that calcineurin inhibitors like tacrolimus, they are given in the renal variety of AKI, but cyclosporin per se affects again the renal hemodynamics, and the balance between the afferent and the efferent arteriole which generates the filtration pressure is affected by these drugs, and therefore they are mentioned as pre-renal causes. I repeat my statement again, cyclosporin is to be answered for a pre-renal cause because it affects intra-renal hemodynamics, but calcineurin inhibitors, that is like tacrolimus, is to be answered as a renal cause. Once we get the pre-renal data right, we will now focus on the renal causes of acute kidney injury in a patient. Well, we can divide this compartment wise. Either the problem can be in the glomerulus, or the problem can be in the tubules, and lastly it could be a vascular issue in the patient. These are the three categories that you need to remember. We will first handle the glomerulus and the vascular part. That is simple and straightforward to remember. Glomerular cause could be like acute glomerulonephritis, or it could be post-streptococcal glomerulonephritis, it could be lupus nephritis, it could be Goodpasture syndrome, it could be vasculitis related to anti-neutrophil cytoplasmic antibody, that is ANCA. So glomerular causes are related to everything having or ending with the word GN, or could be diseases which could be like Goodpasture. When it comes to vascular causes, one of the important ones, and I've shot a separate video for the same, is thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. I will describe these topics in the subsequent slides before you, and you can also listen to a separate lecture on thrombotic thrombocytopenic purpura, but it would be a vascular cause related to the perfusion of the kidney getting compromised. Then is malignant hypertension, in which you read about flea-bitten kidneys and you read about fibrinoid necrosis of blood vessels, is a vascular cause. Then is renal vein thrombosis. Remember, renal vein thrombosis is a renal cause. I'll just draw a diagram subsequently before you and explain to you how it is a renal cause. But at the moment, remember, it would be a vascular cause responsible for the renal variety of acute kidney injury. The next condition that I'm writing before you is very peculiar if you're reading it for first time. And well, a highlight of this disease is eosinophiluria, erythroembolic kidney disease. As the name suggests, there would be some emboli that will be blocking the small blood vessels of the kidney. And I will again explain this disease to you in the subsequent slide. But at the moment, one of the hint in the questions that you will always get with respect to erythroembolic kidney disease is the statement written eosinophiluria. Well, eosinophiluria per se is not diagnostic of atherosclerotic kidney disease. I'm not saying that, but I'm saying that if you read eosinophiliuria in a question, one thought process of yours is that it could be atherosclerotic kidney disease or it could be allergic interstitial nephritis in a patient. I'll explain why atherosclerotic kidney disease develops subsequently, but at the moment the message is this is a complication that is seen with angiography. When you're doing angiography in a person, coronary angiography for example, then your catheter can brush against the atherosclerotic plaque and the atherosclerotic emboli will block the small blood vessels of the kidney and therefore vascular cause of renal failure will occur. When it comes to tubular causes of damage in the kidney, this will eat up a lot of space, so I need to be very particular about it. The mnemonic that I will use for remembering the tubular cause, which will be the most extensive list in the renal causes, would be remembered by the alphabet or mnemonic SIN. Well, S for stand for sepsis, I would stand for ischemia, and N would stand for nephrotoxins, which would be damaging the kidney parenchyma of the patient. Sepsis is straightforward. Mark my words there. What I am saying is not septic shock. I did not say septic shock. If it was septic shock, I would have said it is a pre-renal cause because perfusion is compromised. Sepsis itself can cause damage to the tubules. Why? Because sepsis, the toxins can cause tubular necrosis. The products which are produced in sepsis can contribute to tubular necrosis. So sepsis alone, not only septic shock, that's a complication of sepsis, can contribute to tubular damage. Then is the ischemia component. Well, to explain the ischemia component, I can tell you that 20% of the total cardiac output goes to the kidney. 10% of all the oxygen consumption that occurs in our body is consumed by the kidney. It's not working like the heart. Still, it consumes 10% of oxygen. The weight of the kidney when respect to the whole body is only 0.5%. Look at the statistics here. I said an organ whose weight is only 0.5% of the total body weight is consuming 10% of oxygen and is consuming 20% of the cardiac output. So you can see the functions that it is doing and the amount of energy it needs to do its functions properly so that the filtration processes are working properly. The outer part of the kidney is the cortex, the inside is the medulla. Remember MCQ wise that the outer medulla is the most vulnerable part of the kidney. Alternatively, remember that the S3 segment or proximal convoluted tubule is the most vulnerable part of the kidney. This does active functions and for that you need energy, and if there's ischemia, energy is not there, so the active functions would be lost and therefore in spite of the fact that there might be filtration across the glomerulus, the tubules are not going to do their reabsorption. They are not going to be performing properly. Like their job is to excrete potassium, their job is to excrete hydrogen, so you would have a hyperkalemia and a metabolic acidosis. I repeat my statement. The most vulnerable part of the kidney to ischemia is the outer medulla, especially is the S3 segment of the proximal convoluted tubule. So let me explain what I mean by the word ischemia causing tubular damage to the patient. Let us assume a person is undergoing some kind of a surgery for which anesthesia was required for 2 hours. But because the surgery continued due to some complications for 4 hours, the anesthetic had to give more anesthesia. If you give more anesthesia to the patient, all anesthetic drugs are vasodilators and they contribute to less blood supply to both cortex and medulla. And medulla has relatively more propensity to suffer from ischemic damage. So there's a possibility that kidneys can shut down due to prolonged anesthesia. So post-operative, renal failure can be seen of the renal variety. This is because of the prolonged anesthesia that was provided to the patient that has caused ischemia of the outer medulla. Or I can give another example. This patient was on cardiopulmonary bypass machine. He's undergoing a open heart surgery and he is on cardiopulmonary bypass machine. So cardiopulmonary bypass machine produces non-pulsatile blood flow. That non-pulsatile blood flow can again be a reason why the medulla of the patient may not be able to get sufficient amount of oxygen and may not be able to function properly. What I also mean by post-operative is atheroembolic kidney disease. Now you will notice that I mentioned atheroembolic kidney disease even on the right hand side as a vascular cause. So I want to tell you that this is an artificial classification in which the same disease can be written 2 times also, because you see we have created this classification for our understanding, because we can compartmentalize and identify that okay, this part of the kidney is involved. So when I say atherosclerotic kidney disease, like the person underwent an angiography, the angiography will result in the emboli to be released from the atherosclerotic plaque, and they will block the small blood vessels. So blood vessels are blocked, so that is why we call it vascular. And because there is blockage of the blood vessels causing ischemia, so it is also a ischemic cause. The next statement that I'll mention before you might sound a little surprising with respect to burns and pancreatitis. You see, traditionally speaking, when I say patient of burns, then there would be fluid loss from the body, and he should be classified as a patient having a pre-renal variety of acute kidney injury. But the point is, when you have a patient of burns and pancreatitis, once he reaches the medical facility, what we do is we give aggressive fluid resuscitation in the patient. You see, I'm not saying that a burns patient did not get medical care, then he will have pre-renal. He did receive medical care, he received aggressive fluid resuscitation. In patients of burns and acute pancreatitis, the fluid tends to leak out of the blood vessels, and a person can start developing abdominal compartment syndrome because the capillaries have become leaky due to pancreatitis process, due to burns process, and therefore the person is having, you are pushing in fluids through a wide bore cannula, but all that fluid is going where? Peritoneal cavity, and the patient is developing abdominal compartment syndrome. If the pressure of the peritoneal cavity will become more than 20, it will compress the renal vein from outside. Mark my words there, I'm not saying renal vein thrombosis, I am saying that the abdominal compartment syndrome that will develop here will cause compression of the renal vein of the patient, and therefore again the perfusion of the kidney is compromised. So if a person of burns is not treated, they can be pre-renal, but if it is treated aggressively and there's a fluid leak contributing to abdominal compartment, the definition being more than 20 to 25 centimeters of water, then the patient can end up with renal vein compression and a ischemic damage to the kidney. For the list of nephrotoxins, due to lack of space at this place, I would like to use a different slide to explain the nephrotoxins component to you. There would be two varieties, endotoxins, but before we go to the next slide, let us just revise the information that we've studied here so that we get the orientation right. I said for renal, we are dividing into three components, that is glomerulus, tubules, and vascular component. Glomerulus and vascular, I don't think so you need any effort to remember them separately, because names are like this, no, glomerulonephritis, GN writing, renal vein thrombosis, atheroembolic kidney disease, so you know embolism will occur in the blood vessels. For tubular, remember the mnemonic SYN, sepsis, ischemia, nephrotoxins. And ischemia component can be post-operative, it could be post-resuscitation of a burns patient, and nephrotoxin component is a little extensive. So I will now be explaining to you the aspects related to nephrotoxins, which are responsible for the renal variety of AKI in a patient. As I mentioned, artificial classification is exo and endogenous causes. So let's discuss them individually. First is exogenous causes, which are relatively easy to understand. This person is using Chinese traditional herbal medicine. This could be containing a product by the name of aristocolic acid. This is a toxin which is present in these so-called herbal medicines. It is responsible for what also the textbook mentions as Balkan. Balkan would be central part of Europe, countries like Yugoslavia, former Yugoslavia, Bosnia, Herzegovina, Serbia. So Balkan nephropathy. So this is found in two areas, that is central part of Europe and then in China. So aristocolic acid is a exogenous toxin that the person is taking in thinking that it will increase his stamina, it will increase his daily concentration performance, but it is causing harm to the kidney. The next one is rather more important from exam perspective, aminoglycoside toxicity. Right from third year in medical school, we are taught gentamicin, amikacin are nephrotoxic molecules. But then the MCQ surprises us by saying that aminoglycosides will cause non-oliguric acute kidney injury. I mean, I started the topic by telling you that urine output normal is 1 ml per kg per hour. In acute kidney injury, it will be reduced by 50% or even more. And look at the surprising thing that I'm telling you, non-oliguric renal injury. Non-oliguric would here mean that the urine output of the patient will be more than 400 ml per day. Then how is it possible? Well, you have to understand that aminoglycosides basically cause damage to the collecting duct of the kidney. In the collecting duct of the kidney, we have V2 receptor, which is responsible for reabsorption of water. What will happen is that when this molecule will damage this collecting duct, therefore the V2 component will not be able to function properly, and whatever water is present in the collecting duct, that would still be lost. So therefore the very peculiar terminology I want you to remember is non-oliguric acute kidney injury is seen with aminoglycoside toxicity. Another exogenous agent that you have to remember is amphotericin B. That's again a very standard question. Amphotericin B, which is used in cryptococcal meningitis, can cause renal failure in overdosages. Why? Because it can cause tubular damage in a patient. Then can be anti-cancer drugs like cisplatin. They will again contribute to tubular necrosis in a patient, and a similar manifestation would be developing in a patient. For the next cause, I can give an example like this, that my hospital has declared that today on the World Heart Day, there will be a camp where coronary angiography will be done at a dirt cheap price of only 5,000 rupees. There was a huge rush of large number of patients because my hospital has launched a scheme of an angiography being done at cheap price. Now, I was the only resident on duty who was responsible for filling up the forms of the patient, and unfortunately for my bad luck, this was a diabetic patient with elevated creatinine of 2.5. I, however, did not even check his serum creatinine report, and I sent him for angiography. Angiography will be done, but the bad news is, post angiography, his urine output is gonna fall because the dye has to be excreted via the kidney, and his kidneys are already damaged, so the person will develop a contrast-induced nephropathy. Most of the time in contrast-induced nephropathy, recovery will occur by something like 7 days, but obviously relatives will not be very pleased with you. In fact, they can put up a court case against you saying that, doctor, you did not even bother to check kidney function before you did an angiography in the patient. So always, whenever you're doing a coronary angiography, especially in diabetic patients, do have a look at the serum creatinine report of the patient. At this juncture, I would also like to mention regarding an antidote for contrast-induced nephropathy, which is also taught for paracetamol toxicity, that is N-acetylcysteine. So the exogenous toxins are Chinese herbal medicine, aminoglycosides causing oliguric renal failure, ampho-B, cisplatin, and contrast-induced nephropathy. Let us now look at the endogenous toxins that are developing in a patient. Coming to the endogenous cause, one can be hemolysis, like this person has undergone massive hemolysis due to mismatched blood transfusion, and hemoglobin will block the tubules of the kidney. Or the person was crossing the road, a car went over the legs of the patient, so rhabdomyolysis, myoglobin will block the tubules of the kidney. My next patient is having multiple myeloma, where Bence-Jones proteins can clog the tubules, block the tubules, contributing to damage to the kidney, that is the tubules have been damaged, so it's a renal cause again. Then can be crystals, which I'll use my next slide to explain to you. But these are some of the causes for renal variety of renal failure from the toxin component. So let's just go back to the slide. I've talked about a mnemonic SIN, that is sepsis, ischemia, nephrotoxins. Nephrotoxins is what I've explained to you. And I will just use this opportunity to explain a little more what I mean by the crystals aspect here. 1. A patient has consumed antifreeze agent. What I mean by antifreeze is that you see in a cold Delhi in month of November, when temperature is 2 degrees Celsius, when you turn the ignition key of your car, the car will start with the first self ignition. That's because there's an agent in the car engine which will ensure that the engine doesn't freeze up or seize up, and it can start even in an extremely cold environment. Now this chap has consumed this antifreeze agent, and the end result is that this person will be having production of calcium oxalate crystals, and these calcium oxalate crystals will block the tubules of the kidney. The antifreeze agent may even be written as ethylene glycol poisoning. In fact, this is a question by itself, that ethylene glycol poisoning causes tubular necrosis due to, then your answer would be precipitation of calcium oxalate crystals, which will block the tubules of the kidney and cause this unfortunate complication. What will you do to prevent this from happening? You will use an antidote that you even use in methyl alcohol poisoning, that is fomepizole. So fomepizole is an antidote for two things. It is antidote for methyl alcohol poisoning and even for ethylene glycol poisoning, and crystals can cause damage to the kidney. Let's take up one more such scenario. This time I'm describing a patient with a blood cancer. I've shown a cancer cell. Cancer cells will always be having an extensively basophilic nucleus. extensively basophilic nucleus. The nuclear cytoplasmic ratio will also be distorted. So blood cancer will always be having what we call as anaplasia. Anaplasia implies that the nuclear cytoplasmic ratio is distorted. The nucleus is more basophilic, and more bigger nucleus means that it will be having more amount of DNA. The importance of knowing this would be that DNA will break down to produce uric acid, and those crystals can block the tubules of the kidney. What I'm explaining to you next with respect to crystals is called as tumor lysis syndrome. I am planning to start chemotherapy in a patient of blood cancer. The good news is I will kill the blood cancer, but the bad news is when you will kill these blood cancer cells which are loaded with potassiums, millions and trillions of them simultaneously, then potassium in the blood will suddenly rise. Whenever you give chemotherapy to any patient, the sudden death of multiple cancer cells will cause hyperkalemia. The adenosine triphosphate will generate phosphate, and this phosphate will chelate with calcium. Remember my words, the high phosphate will chelate with calcium, so ionized calcium and total calcium values will decrease because phosphate is binding to it. And the DNA breakdown in the patient will result in production of uric acid. These uric acid crystals will block the tubules of the kidney and would contribute to development of acute tubular necrosis and a renal shutdown in the patient. I was thinking that I'm doing benefit of the patient, but unfortunately I'm having a renal shutdown. Well, the learning from this discussion is that whenever you are planning to start chemotherapy in any patient, don't start chemotherapy in the evening hours and then go back home. Why? Because there would be less doctors in the hospital to monitor the case. So if you have to start chemotherapy in a patient, one, you should start in morning hours. Why in morning hours? Because one, more doctors will be available to monitor the patient, and second, if I plan to start chemotherapy in my patient, let me say tomorrow morning, then today before I go, I have to ensure that I start a normal saline drip in the patient to ensure adequate hydration of the patient. I want to achieve good hydration and a good diuresis of the patient, and if he will be distressed by going to the washroom again and again, walking to the washroom again and again, I can put in a condom cath in the patient so that he is avoiding the hassle of going to the bathroom, but kidneys will be well perfused before chemotherapy started. So today evening, before I went home, I ensured good hydration of my patient, and tomorrow morning I can start chemotherapy. Unfortunately, in spite of all the precautions I took, still tumor lysis syndrome does occur or can occur in the patient. In those circumstances, what will you do? You will ensure hydration of the patient. You will start furosemide drip. That's the standard protocol. Do not give furosemide bolus, but give a furosemide drip to the patient. Then the drug that can be added here is allopurinol, because it will inhibit the synthesis of uric acid, would be given intravenously. You will also use a drug by the name of rasburicase that will break down the uric acid which is causing blockage of the kidney tubules of the patient. Though there are side effects with rasburicase, I can say the fact that overall the drug of choice for tumor lysis syndrome is rasburicase only, but the first line management for the person is not rasburicase. We will start fluids, give furosemide, give allopurinol, then give rasburicase to the patient. To the previous batch I taught them urinary alkalinization, but now urinary alkalinization has been removed from the protocol of management of tumor lysis syndrome in a patient. So if you're listening to this lecture the second time, you will notice a slight shift in the information, in a sense that urinary alkalinization that I spoke earlier, I have mentioned that it has been discontinued. So the crystals aspect that I've explained to you are two to be remembered. One is antifreeze, that is ethylene glycol poisoning. Second is tumor lysis syndrome in a patient. Both of these are responsible for tubular shutdown and explains the toxins which are the endogenous toxins which will cause a renal compromise in the patient. I shall now explain to you regarding one of the vascular causes responsible for renal variety of acute kidney injury. The topic that I'll explain here is RVT, renal vein thrombosis. Let us assume this to be a representation for the renal artery and the subsequent one for the renal vein, and my patient is unfortunately having a thrombus occluding the renal vein. Therefore, the blood is going in the kidney, it is not able to come out. This will result in development of extensive amount of congestion in the kidney parenchyma of the patient, and the kidney will become enlarged. If you read a question that is describing to you regarding renal shutdown by talking about features of anuria, metabolic acidosis, hyperkalemia in a patient, and then goes on to say that in this particular individual with AKI, there is a unilaterally enlarged painful kidney. Remember my words, in hydronephrosis you can again be having a unilaterally enlarged kidney, but it is not a painful kidney. But unilaterally enlarged painful kidney is a feature that is encountered with RVT, that is renal vein thrombosis. The investigational choice for identification of this condition would be answered by you as Doppler, because there would be a drop in the signal due to the blockage of the renal vein of the patient. And the bad news is that this thrombus which is formed here can embolize from here, and these emboli can then travel via the inferior vena cava to the lungs of the patient. So one of the complications that can be seen in patients of renal vein thrombosis is pulmonary embolism, and then you will have to handle the patient on lines of either a massive or a submassive pulmonary embolism. Renal vein thrombosis is to be remembered because of the etiology also. Why does it occur? Well, when it comes to pediatrics MCQ, like it begins by describing a child, then you have to think in terms of diarrhea with dehydration. You see, if a person is losing lot of water from the body, then the packed cell volume in the body will increase. There would be increase in viscosity, sluggish circulation, that can explain the development of RVT. If it comes to adult, then the cause is very peculiar. It is associated with one of the causes of nephrotic syndrome in geriatric population, that is MGN, which is called as membranous glomerulopathy. So RVT or renal vein thrombosis can cause pulmonary embolism. It is caused by, so one is the manifestation of it, one is the cause of it. Both have to be remembered. Hydronephrosis has a unilaterally enlarged kidney but never a painful kidney in a patient. Another aspect, though I have spoken about it, but still I can say a few more words, are like this. Crush injury will always be having a red color urine. Do not answer rifampicin for red color urine because it will have an orange discoloration of urine. So red urine is a feature that you one read with porphyria. Then obviously can be beetroot ingestion. The third reason why you read about red urine is crush injury, myoglobin. And then can be urological causes. That could be like the person is having a bladder stone, bladder outlet obstruction, and the edges of the stone are jagged, so it's blood mixed with urine that is coming in the patient. In fact, urological causes are one of the important causes of gross hematuria. Microscopic hematuria is obviously Burgess disease. The problem in crush injury is that myoglobin will physically block the tubules of the kidney, and therefore there would be a renal shutdown developing in a patient. Similarly, let us assume that a person, he is a soldier and he is posted in Chhattisgarh or he is posted in Northeast where terrorists or Naxals are there. So this particular individual, he is a commando and he is operating deep inside the jungles. In the jungles, obviously, there would be mosquitoes, and with mosquitoes would come falciparum. So when these troops go out on missions, the doctors attached to the unit will give sufficient amount of artesunate to the soldier, explain to him the symptoms of malaria, and tell him that if you start having fever, chills, you have to start taking artesunate. But sometimes in falciparum malaria, the parasitemia can be so much that there can be extensive hemolysis occurring in the body of the soldier, and this hemolysis will cause the soldier to pass a black color urine that would be called as a black water fever, which is a complication of falciparum malaria, and hemoglobin will block the tubules of the kidney and the kidneys will shut down. So it could be crush injury contributing to this, it could be falciparum that could be contributing to the same, that is hemoglobinuria will be blocking the tubules of the kidney. The manifestation can be written as black water fever. These are some of the miscellaneous causes that I'm describing before you, though I have mentioned them in the table that I was trying to explain to you earlier, but then a little bit of extra information would help you understand better why the manifestations are occurring in a patient. Another cause to be remembered and has been enumerated earlier is atheroembolic kidney disease. Let us see how it will show its manifestations. I have a patient in my hospital today who is undergoing coronary angiography. This is the aorta of the patient, this is the renal arteries which will be supplying the kidneys, and then the aorta will end up in the iliac arteries. This is the iliac artery bifurcation. My patient is having atherosclerosis involving the abdominal aorta, so yellow is representing the atherosclerotic plaque which is present in the abdominal aorta of the patient. The red is representing the guide wire. This guide wire of mine is going up from the femoral artery because I want to do angiography. So I'll first send up a guide wire, then send a catheter and do angiography. So this guide wire of mine or the catheter which I am sending upwards has gone upwards, causing a damage to the atherosclerotic plaque. You can now notice the fact that once this catheter scrapes against the atherosclerotic plaque, there could be formation of multiple embolic fragments of this atherosclerotic plaque, which will then travel downstream into the renal artery of the patient, into the smaller blood vessels of the kidney, and will cause ischemia of the kidney. It will contribute to blockage of the small blood vessels of the kidney. So this would be classified as both a vascular cause as well as a ischemic cause for shutdown of the kidney of the patient. Atheroembolic kidney disease is also a complication that is encountered post angiography. There is a renal shutdown. I have today described two scenarios to you where a person in my hospital underwent a coronary angiography and a renal shutdown is present. If you read regarding post angiography renal shutdown, and he also mentions regarding a urine microscopic examination finding of eosinophiluria. He also mentions the fact that in this patient the pre-existing kidney function test, serum creatinine that was done before the procedure, I'm writing the word pre, before the procedure was normal, and post procedure the creatinine value has jumped up to double or maybe triple, then it is atheroembolic kidney disease. Remember, if a person is having contrast induced nephropathy, then the serum creatinine before the procedure will obviously be elevated and post will further be elevated. I repeat my statement, if a person of diabetic nephropathy, his serum creatinine is 2.53, I was busy in a sense that I did not even look at his report properly. I sent him for angiography just like that without checking the KFT report of the patient, because the creatinine before the procedure is already elevated and post will be elevated even further. This indicates that person has undergone a contrast-induced nephropathy and has a relatively good prognosis. Recovery occurs by usually 7 days because the kidney will finally able to excrete the dye. But in atheroembolic kidney disease, we have a relatively bad prognosis. And what are the hints in the question? I repeat once again, eosinophiluria and pre-procedure serum creatinine is normal, and then there is an elevation of creatinine. It means it is atheroembolic kidney disease. If primarily it was already elevated and there is a further spike, it is contrast-induced nephropathy in a patient. Another point that might help you in MCQ that this is a patient having atheroembolic kidney disease could be this word written, that is livedo reticularis, which means the fact that these atheroembolic emboli will spread via not only into the renal artery but into the whole body of the patient, reaching out to the skin. So you would be having a fishnet appearance of the skin. This fishnet appearance of the skin is called as livedo reticularis. Another information, if given, is a bonus for you, that is mention of retinal plaques, because obviously these atherosclerotic emboli will distribute everywhere. So if he says the word Hollenhurst plaques or he says retinal plaques, then it gives more credibility to the diagnosis of atheroembolic kidney disease in contrast to contrast-induced nephropathy that I mentioned. These are the two complications of coronary angiography that you should be remembering. Another renal cause that I want you to remember is called as HUS, hemolytic uremic syndrome, which is also called as TTP, thrombotic thrombocytopenic purpura. This is caused by a bacteria that is E. coli O157H7. I have shot a separate lecture on thrombotic thrombocytopenic purpura in the kidney section. You can go through that. But this bacteria can produce a toxin that is called as Shiga toxin that will activate the complement system and can cause a complement mediated hemolysis. The damage occurs in the small blood vessels in the kidney. Therefore, we call it MAHA, microangiopathic hemolytic anemia. I repeat my statement. The H here stands for MAHA, that is microangiopathic hemolytic anemia, where when you will do peripheral smear of this individual, you will be able to notice normal RBCs, and then you will be able to notice these Helmert cells or schistocytes. These would be the dead RBCs which have been damaged by the complement system. So hemolytic uremic syndrome 1 has a H, that is microangiopathic hemolytic anemia. Instead of writing MAHA, he might write the word Coombs negative hemolytic anemia. The peripheral smear finding would be very characteristic Helmert cells which are shown here. The second feature that will develop in this patient will be renal failure or uremic manifestations, which can range from development of encephalopathy, nausea, vomiting, uremic pericarditis, uremic melena. So he will describe two things. First, he will say that the person had diarrhea/dysentery. and approximately after 7 days or so, he is having severe hemolysis. The relatives are thinking that your medicines that you gave for treatment of diarrhea have caused some reaction. Even you might get an impression like that. You treated somebody with a drug and suddenly his hemoglobin is falling. Relatives are asking you for questions. They're saying, "Sir, what happened? This guy's hemoglobin was 15, suddenly it dropped to 5. He might even go into heart failure." So he was treated by you by maybe antibiotics or conservative management, but the end result is that this bacteria is causing destruction of red blood cells. It is causing microangiopathic hemolytic anemia and a renal shutdown in a patient. So this presentation is usually called as typical hemolytic uremic syndrome. It might even be written as D positive HUS. You might also read the word D negative HUS. So drugs can contribute to anti-cancer drugs, anti-rejection drugs. They are known to cause similar presentation of causing a hemolytic anemia followed by uremia in a patient. So D negative hemolytic uremic syndrome is seen with drugs. It is called as atypical HUS, and typical is going to be seen with E. coli O157. This would again be called as a renal cause. And one more very interesting fact that I would like to say about HUS is that don't give antibiotics. Studies have shown that giving antibiotics in hemolytic uremic syndrome rather worsens the mortality rate by as much as 17 times. Why? Because when you kill this bacteria, the toxin that is released in sudden large amounts causes extensive complement activation and causes sudden deterioration of the patient. So we manage these patients conservatively, and if required, we might have to do even dialysis in the patient for management of the uremia component. So these is a list which I took a while to describe the renal causes. And last but not the least, I'll mention the post-renal causes, which are relatively simpler and easy to comprehend. For the post-renal causes, one can be obviously bilateral stones in a patient at a pelvic-ureteric junction. But because that is relatively, I would say, very unlucky patient that is having two stones both at the pelvic-ureteric junction causing a post-renal failure, we will talk about a cause which is rather more important, and that would be bladder outlet obstruction. Like in this case, I've shown a person having BPH, benign prostatic hyperplasia. He's having poor urinary stream, and if he does not get surgery done, then the median lobe enlargement can even cause urinary retention and subsequently a renal failure. Instead of BPH, it could also be a blocked Foley's catheter, or it could be bladder outlet obstruction due to stones. It could be bladder outlet obstruction due to tumor. Then can be possibility of bilateral ureteric fibrosis, as I've shown here before you. This bilateral ureteric fibrosis that I have highlighted could be associated with scleroderma, or could be seen with a drug that is bleomycin. I'll just mention the name here, bleomycin. Also with connective tissue disorder, in which you get anti-topoisomerase antibody positive. These are the associations that are to be remembered by you for post-renal variety of acute kidney injury, and if we ask you to select one, it would be benign prostatic hyperplasia. Let us now look at the clinical features that would be seen in these patients. Clinical features of acute kidney injury. The reason why the patient will come to you will be primarily because of the fact that the urea in the body will start accumulating. This urea will start causing irritation of the stomach mucosa of the patient, and therefore most patients, due to elevated urea causing irritation of the stomach mucosa, will be having development of very severe vomiting. One of the early symptoms in these patients is not going to be answered by you as renal shutdown, because that takes time to happen. It will be rather vomiting in a patient. The elevated urea will irritate the diaphragm of the patient, and irritation of the diaphragm of the patient will be responsible for development of hiccups. So most patients are having GI complaints initially. The urea that will accumulate in these patients will also be responsible for inflammation, or it's a toxin mediated damage to the pericardium. It will cause pericarditis that will explain the chest pain, which might be severe enough to necessitate a hemodialysis. As the levels of urea in the body will rise, the elevated urea will cross the blood-brain barrier. And once it will cross the blood-brain barrier, then water will also go, because urea is a osmotic molecule. So to balance the load of urea, water will also go in the brain. And when water will go in the brain of the patient, water going into the brain of the patient, that will cause cerebral edema. Cerebral edema will cause encephalopathy to manifest in the patient. And before the development of encephalopathy, you might be able to demonstrate the presence of asterixis in the patient, that is flapping tremors. The toxins are causing problems for this guy. The glomerular filtration rate of the patient is less, so renin will increase and high blood pressure will occur. In fact, in acute kidney injury, there can be so high blood pressure that patient can develop hypertensive encephalopathy. Whenever a patient with hypertensive encephalopathy presents to your hospital, you must always think of kidney involvement. Hypertensive encephalopathy either occurs due to kidney involvement or endocrine involvement, and renal involvement usually causes very high blood pressure to the range of, let me say, 220 by 130 with evidence of papilledema, that is target organ damage, is already demonstrated in the patient along with renal shutdown. That will gonna happen very soon. In these patients, because there will be volume overload, you see the kidneys are not being able to excrete all the water, so volume overloading will occur. This volume overloading will explain the puffy eyes that will develop in these patients subsequently. The volume overload will explain the development of pulmonary edema in these patients. So all patients who are having AKI can subsequently develop pulmonary edema, and due to this pulmonary edema, they might be having breathlessness that might make you feel as if you're dealing with a cardiology case. The pulmonary edema will worsen with the supine position because volume overload is causing congestion in the heart. So position dependent dyspnea might be seen. It is only later that we realize that it is renal shutdown that is the cause of all these complications that is developing in the patient, and we will be either having a oliguria and then a anuria in the patient, anuria being defined as urine output less than 100 ml per day. So these are the usual reasons. They start with GI complaints and then end up with development of renal shutdown with high blood pressure and volume overloading causing puffy eyes and dyspnea. Now you will have to do a workup of the patient, and for workup of the patient you will be doing a KFT that will show a deranged elevated serum creatinine. The rise of the serum creatinine of the patient will be directly proportional to the damage in the kidney. Like if it is injury, you might be having doubling. If it is a tripling, it could indicate a failure. In these patients, you will also get electrolytes checked. On evaluation of the electrolytes, you will notice sodium will be less and potassium will be high. You see, sodium is less because of the dilutional effect, because there's a water overload in the patient. There is a presence of a hyponatremia in a patient. This I would call as hypervolemic hyponatremia. Renal failure is an example of hypervolemic hyponatremia developing in a patient, and because of inability to excrete potassium, the potassium values will also spike in the patient. Since potassium values will spike in the patient, it's a good idea to do a ECG, and the ECG can demonstrate presence of hyperkalemia in the form of presence of tall tented T waves. So you can see in the figure that if you will be doing ECG in this patient, you will be able to demonstrate the presence of very big, they are bigger than the QRS complex. I mean, they are bigger than the QRS complex. This is the QRS complex, and the R wave is bigger, and you can also notice some magnitude of ST elevation. So ECG finding of ST elevation is seen in this image. Along with ST elevation, which is present, if I just zoom in, ST elevation, which is present, you can also see the presence of tall tented T waves. In all of these patients, you will also be getting ultrasound of the kidneys done to rule out the postrenal causes. You also have to do a ABG in the patient because you want to demonstrate the presence of metabolic acidosis. Whenever the kidneys in the patient are damaged, the pH of the patient will be lesser. pH of the patient will be less than 7.35 and bicarbonate values in the patient will be less than 22. So metabolic acidosis will be a manifestation in the patient. Once you've demonstrated the electrolyte imbalance and acidosis in a patient with development of deranged KFT, your job is to now identify which type of renal failure it is, whether it is a pre or a renal variety. Post renal can be picked up on ultrasound, but for pre renal and the renal variety, The description is like this. Listen to the input, then I'll mention the test. Let me say this is a representation of the glomerulus, the tubules. Afferent arteriole, efferent arteriole, and then the tubules. You see, the point number 1 to be understood is that in the proximal tubule, you have transporters which help in absorption of salt, which help in absorption of sugar. Like I have shown a transporter that is responsible for salt, sugar, and it also helps in absorption of water. So SGLT2 is what is represented here in the tubules. It is responsible for absorption of salt and water. If in a patient there is a tubular damage, that is the renal variety, then I'm just symbolically putting a cross here to say that this function will not occur. If this salt absorption will not occur, you can see that all the salt will be lost in the urine of the patient. So on the right hand side of the patient, since the patient will be having salt wasting, because salt can't be absorbed, tubules is damaged, I will be checking urinary sodium of the patient, and the urinary sodium of the patient on the right hand side will be relatively high. The reason why urinary sodium is high is because salt is not getting absorbed. On the other hand, let me say my patient is having cholera. In cholera, there is water loss from the body. So patient will be having less perfusion of the kidney, dehydration that can cause renal shutdown in the patient. If a person is having dehydration, the blood supply to the kidney in the glomerulus is lesser. Because the blood supply to the kidney is lesser, this transporter will try to upgrade the absorption of salt, water, and sugar. So I will just symbolically show that there is more salt, there is more water that is coming back. I have just made the arrows relatively bigger to say that the body is trying to reabsorb the osmotically active molecule like salt. It is trying to reabsorb water so as to compensate for the dehydration component of the patient. Therefore, in this particular case, because all the salt will go back, the urinary sodium of the patient will be relatively low. So part number 6 of mine is regarding urinary sodium. I'll say this again in case you missed it out. If you focus on the right hand side of the discussion, you can see the fact that on the right hand side I have shown damage to the tubules. If tubules are damaged, then salt cannot be absorbed from the PCT and there would be salt wasting, so high urinary sodium. And on the left hand side, because salt and water both are less in the body, because the cholera causes loss of both of them. So body is trying to reabsorb the salt and the water, and therefore you will notice that urinary sodium would be low, and therefore the test that I'm describing here before you is urinary sodium, or it is also written as FeNA. FeNA would stand for fractional excretion of sodium. Fractional excretion of sodium is low in cases of pre-renal variety. Cholera is like pre-renal variety, whereas fractional excretion of sodium is more than 1% in the tubular damage. Example of tubular damage is acute tubular necrosis. So in MCQs, whenever you read the word FeNA, fractional excretion of sodium less than 1%, it is indicative of pre-renal variety. And whenever you read FeNA, that is fractional excretion of sodium more than 1%, it is suggestive of the renal variety. You can differentiate between the pre-renal and the renal variety of kidney failure by doing a fractional excretion of sodium in the patient. We can practice this once more. Look at the representation for pre-renal and the renal variety. Let's start from the right hand side. What I will do is I will talk about another test that is called as urine osmolality. You can see that on the right hand side. Let me just zoom it in. Right hand side, you can see that water is not getting absorbed. If water will not be absorbed, even water will be lost here. If water will be lost in the urine, just get by my English words. In this case, water will be lost in the urine of the patient. So urine will be relatively dilute. So the urine osmolality of the patient on the right hand side will be relatively low. I'll repeat the data again. You can focus on the right hand side of the image. You can see water is not getting absorbed. So water will be lost in the urine, and loss of water in the urine means urine osmolality will be low. Whereas on the left hand side, water is gonna be reabsorbed. So when you check the urine osmolality, the urine will be concentrated. Urine osmolality can also help you in identification. Urine osmolality is always higher in the pre-renal variety. Usually, the urine osmolality in the pre-renal variety is in the value of 500 milliosmoles or higher. and the urine osmolality in tubular damage is usually in the range of lower side, that is 300 milliosmoles or around about that value. So two tests that can differentiate between whether it is pre-renal variety or the renal variety is urinary sodium and urine osmolality. I repeat again, urinary sodium and urine osmolality can help you in differentiating between the two varieties of renal failure. In case the urinary sodium is high and urinary sodium is low, urine osmolality is low, it means the fact that there is a salt wasting and there is a water wasting also. Water wasting will cause urine to be dilute. On the left hand side, cholera, body is trying to get back all the water it can because there is loss of water, survival instincts, right? So body will try to get back all the water. So urine will be concentrated and there will be less salt loss also because the body will try to get back most of the salt back into the body. FeNA, fractional excretion of sodium, is one of the best ways to identify the pre-renal variety from the tubular damage, that is the renal variety, apart from the other tests that I mentioned. And then will be the treatment of the patient. For treatment of acute kidney injury, you will have to maintain fluid balance in the patient. So the input of fluids that you give to the patient will be equal to the urine output of the patient plus insensible losses. Like if urine output is 0 in the last 24 hours, then only replacement for insensible losses will be given. Insensible losses are in a range of 400 ml to 800 ml. Insensible losses are in the form of water vapor. Like when we talk, when we breathe, there is loss of water from the body, water vapor. Insensible losses are also in the form of stool, having water loss. So two main mechanisms of insensible water losses are water vapor and stool containing water. Sweating is also a component that is related to not exactly insensible losses, but I would just like to say the fact that if the patient is in an air conditioned ward, sweating will almost be zero, and most of the wards nowadays are air conditioned wards. So sweating will not be occurring, though in government hospital, if you know a patient is in a hot Indian summer in a ward, sweating will occur. So we need to in a non-AC ward, I will take the insensible losses to be in excess of 800 ml. And in case of air conditioned ward, I'll take it on a lower value, like something in an average of 600 ml. So the point is as simple as this, that insensible losses is a range of 400 to 800 ml, water vapor and water sensory losses, water losses in the stool. Sweating is less likely in an air conditioned ward to be a cause. So if sweating is a component, yeah, I should give insensible losses on the higher side. I'll give insensible losses as 800 ml if sweating is present in a patient. So input fluid that I can give to the patient is 10% dextrose. I would not like to give any electrolyte rich solution at the moment because there is a dyselectrolytemia. So all I would like to give is some water and some calories for the patient, and that will be proportional to the urine output of the patient. Let me say the urine output of the patient is 0 ml. Then only I will give 400 ml of 10% dextrose in the entire day to the patient. This 10% dextrose is the input fluid which is required for the patient. Some water requirement for insensible losses has been provided with calories. I will now be adding furosemide to the bottle of IV fluid, or you can give it via infusion pump. Never give furosemide bolus to establish renal failure. We should be giving furosemide in the form of a drip to a person having a renal failure, so that we can enhance the glomerular filtration rate. I want to achieve diuresis in a patient and I want to wash out the toxins from the body. In these patients, because there is a dyselectrolytemia and there is a hyponatremia in a patient, hyponatremia correction might be required. If hyponatremia is serious enough to cause seizures, if hyponatremia is causing development of seizures in a patient, then you might have to give hypertonic saline to the patient, that is 3% saline. There is no need to give 3% saline if hyponatremic seizures are not present in a patient. The correction obviously has to be slow to prevent pontine melanosis. For management of the hyperkalemia of the patient, especially if the values of potassium are in excess of let me say 6.5 milliequivalents, then in a patient the risk of cardiac arrhythmias will increase. So if potassium is very high in the patient, the drug of choice that can lower the value of calcium in the blood is calcium gluconate. That can antagonize the effect of potassium is calcium gluconate. Please remember that calcium gluconate does not cause any potassium values to change. It is insulin drip that is used to send potassium inside the cells. So this would be regular insulin drip that would be given to the patient to send potassium inside the cells. Only insulin causes potassium influx into the cells. Calcium gluconate is just given to antagonize the potassium effects in the patient. So calcium gluconate is the drug of choice for acute hyperkalemia followed by insulin drip. I can also be using salbutamol nebulization for the patient. It will also send potassium influx into the cell. If in spite of everything that I have said here before you, the potassium values are very high, I might have to do hemodialysis in a patient. Hemodialysis is the most effective method. If the question is asked as, which is the most effective drug for management of patients of hyperkalemia, if the question says, what is the most effective drug to lower elevated serum potassium, the most effective drug to lower is insulin. But if the question says, what is the most effective method to lower the serum potassium of the patient, then the answer is hemodialysis. Therefore, dyselectrolytemia and fluid balance is of paramount importance for management of the patient. If the patient is having metabolic acidosis, which will obviously be present, if the pH of the patient is less than 7.2, intravenous soda bicarbonate may be given to the patient to stabilize the pH of the patient. Because the blood pressure of the patient is very high, patient has gone into hypertensive crisis, he has gone into hypertensive encephalopathy. So for management of hypertensive crisis / hypertensive encephalopathy, the molecule that I will be giving to the patient can be intravenous labetalol. I can either be using labetalol in the patient, or instead of labetalol, I have multiple other drugs available like phenoldopam or urodipil that can be given to the patient. So drugs like nicardipine are available. I mentioned that in the CNS component actually. So nicardipine, labetalol, phenoldopam are molecules which are useful for hypertensive crisis. So all the derangement that I have mentioned here before you can be managed medically. But uremia and its manifestations like uremic pericarditis, uremic encephalopathy cannot be managed with drugs. So once uremia features will develop in a patient, you will anyway have to do a hemodialysis in a patient. Question to you guys why I write it is that where will you do a hemodialysis from? Because here you don't have time to create a fistula. You see, if hemodialysis needs to be done something like 3 times per week for like whole life of the patient, I will be creating a fistula between the radial artery and the basilic vein. That is a seminobrestia fistula that I mentioned in the initial discussion. Now here hemodialysis needs to be done once or twice, maybe 3 times. We do not need to do dialysis again and again. So if hemodialysis needs to be done in a patient maybe once or twice because kidney will anyway recover, then we will be using a central access. So we can be using a subclavian double lumen catheter in the subclavian vein, or we can use internal jugular vein. Hemodialysis from internal jugular vein or hemodialysis utilizing the subclavian vein is to be done in those cases where the uremia features are developing, and hemodialysis is the most effective method to treat this patient, and then recovery will occur. Once the patient will go into a recovery phase, then there will be passage of large amount of urine. In recovery phase of polyuria, in recovery phase of kidney injury, there is a development of polyuria. Because of polyuria in the patient, what can happen is, due to loss of water from the body, hypernatremia can occur. Loss of water from the body, relative hypernatremia can occur. And because in this particular case, there is going to be development of, loss of electrolytes from the body. So most of these patients, the electrolyte imbalances can be opposite. Electrolyte balances can be opposite. Like instead of hyperkalemia, he can be having hypokalemia again because of urinary loss of potassium. So recovery phase of AKI, the electrolyte imbalances are opposite to the electrolyte imbalances that are found in the initial phase of kidney damage. I have not gone into the pathological component of like a initiation phase or a maintenance phase. but I've tried to compromise. I've tried to emphasize the main clinical features that are asked, and I've also tried to talk about active intervention that needs to be done in patients of acute kidney injury. And if all these procedures that I've described before you are done on time, then in the patient we will be definitely able to ensure recovery of the kidney function. It is all about early identification. So most patients will recover. Some can go into acute on chronic kidney damage, but recovery is definitely possible with early identification in acute kidney injury. And the etiology wise discussion that I've had is the one which is MCQ is important. Thank you.